Thank you for joining us for tonight's rheumatology update in partnership with St George Hospital. My name is Bertha and I'm the CPD and Events Manager at Central and Eastern Sydney PHN. Before we begin, I would like to acknowledge the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respects to elders past, present and emerging. I also extend that respect to any Aboriginal colleagues joining us tonight. So I would like to hand over to our facilitator tonight, Associate Professor Ivel Katz. Thanks, Ivel.
Thanks, Bertha. And thanks, Professor Paul Bird, for joining us today and for being so kind to speak to us around managing immunotherapy and comorbidities in rheumatic diseases. Paul has been working for over 20 years in the area of rheumatic diseases and has particular expertise in rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and he's pursuing research alongside clinical medicine and patient care. And Paul completed his PhD in 2005, examining MRI in rheumatoid arthritis, and did a graduate diploma in MRI. He continues to do research with fellow Australian rheumatologists and with international colleagues. And of course, he works in Cogra and in our area. So we are very fortunate, to be able to have these integrated care rounds and specialists from St. George speaking to us. And of course, this is not my area of expertise, so I'm going to be learning a lot myself, and also looking forward to hearing specifically from GPs who are interested in this area. As Paul said, we'll be taking questions at the end, but if you do have questions, please put them up in the chat and we'll manage them at the end. Thanks, Paul, and welcome.
Thank you very much. Thanks for having me.
Okay. So as you all know, the Integrated Care Chronic Disease Network is working together with PHN to run these education programs. And we run a series right through the year, and we appreciate having people involved. We obviously always look to have more people from general practice join us in this group. The more people we have, the more we can do things together, the more GPs that can be involved. And also, ultimately, we'd like GPs to be facilitating and sort of linking us between the primary care and tertiary institutions. So I look forward to people being interested. If they are, they can contact myself or Kylie Turner, who is the chair of this committee, or Bertha, who's also involved. Thanks, Paul.
Pleasure. Thanks. And thanks very much for that introduction. And thanks for having me. I'm going to take you on a sort of a broad narrative tonight on rheumatic disease, but also co-managing immunotherapy in general practice and some of the principles of what we do in modern rheumatology. Three diseases where we've really made major changes in the last 20 years, rheumatoid and psoriatic arthritis and ankylosing spondylitis. And I think we can say the outcomes for these patients now are vastly different than they were 20 years ago. We rarely see deformity in rheumatoid and extra-articular features. In psoriatic arthritis, we almost never see deformity, and we can get the skin and the joints better. In ankylosing spondylitis, that gentleman you see there at the bottom, thankfully, we don't see that sort of appearance very much anymore. We're going to focus a little bit on psoriatic arthritis, but still the principles are the same. We'll start by using a case. This is a patient of mine. Her name has been changed, but she's 46. She's single and works at Coles, and she's a picker, so she does stacking at night time, does a lot of night stacking. She's an ex-smoker. She smoked 16 to 30, has a fair bit of psoriasis on her scalp and extensive surfaces, and has previously had PUVA. She has polycystic ovarian syndrome, metabolic associated steatohepatosis and obesity. She's busy at work and she eats on the run, and as you can see from her BMI over there, unfortunately, she's in the range where she's struggling to lose weight and probably has all of her life. Family history of psoriasis and colon cancer. She's now a non-smoker, as I said, and she lives alone. So for her, access to medical care is about, a lot of it is about cost and how much she can afford. This is what her hand looks like, and you can see this very nice demonstration of PIP joint swelling there. So many of these patients have oligoarthritis like that, 1 or 2 joints involved. She's got very nice psoriasis involving the extensor surface there. She's really treating topically. And the other thing you notice in these people, which often predicts a poor outcome, is pitting in the nails. So she's got nail involvement. As she fits into, just to frame this rheumatologists, of course, it's not good enough to have one label. We like to split it up and make it even more complex. But what we're trying to do with this is capturing all the different features we see in these patients. So we now turn this spondyloarthropathy. And as you can see, psoriatic arthritis here fits in this spectrum. It's mainly peripheral, but there can be axial manifestations. So when you see me writing spondyloarthropathy in my letters, I'm either referring to someone who might have IBD-related SPA, in which case I'll note that, a reactive arthritis, who we don't see very much these days, commonly psoriatic arthritis, and then some people are just undifferentiated. They don't fit into any category, and we call them that, undifferentiated peripheral SPA, and the treatment's fairly much the same. The prototype in axial is AS, but of course we have this category now of non-radiographic, these people who don't get a lot of damage, but they have a burden of disease similar to those with AS. So why put this here? Well, the important point to remember is that these patients can have inflammatory lower back pain and very often have these features here that you can see, the finger involvement, the nail involvement, the swollen digit, those sort of things. But also they have, quite commonly, they'll come in with an unexplained swollen knee, or they'll have things like refractory enthesitis. So they'll be the people who complain to you of bilateral Achilles that's hung around for a long time and won't get better. So there's many features. And the last one, of course, is dactylitis. This is fairly pathognomonic for spondyloarthropathies. So let's go back to her. She has psoriatic arthritis. And just to point out, one of the big problems in people with psoriatic arthritis is they struggle to lose weight. They've often got a gene that makes them have the metabolic syndrome. And even though she's tried these two, Duramine and low calorie restriction, she can't lose weight. She has discussed these, but she can't afford them. And she'd use Wegovy now being available on the TGA. Fasting BSL, HbA1c are not ideal. And she's got some MASH, as we talked about before. And CRP and ESR are elevated, and they often are in these people who are overweight. It's often going to be very difficult until you get the weight down to normalize that ESR and CRP. But nonetheless, she's got active disease. And let me show you what happens to these people. And this will give us a framework to discussing the medications that we use. So as I said, she's got worsening symptoms. And by the time she sees me, I can confirm on examination that she's got an effusion of a knee, synovitis of a wrist. She's got enthesitis. Enthesitis is very common in patients with psoriatic arthritis. And she's got quite bad psoriasis. And this is what she's been doing. Take a lot of non-steroidal, these people, which is not ideal. So our aim is to try and get them off those. And she's had some lower back pain, which is mechanical, and her x-ray is normal. So what happens to these people when they see me is they'll go on to slazoparin for 3 months. It doesn't work very well for their psoriasis, but we have to do it to get them to PBS. And then they'll go on a second drug for 3 months, which is usually methotrexate, but it may be leflunomide. As you can see in her case, often when we put people on methotrexate, their liver function tests worsen. So let's talk about this group. This brings us to this group of drugs. It's our first practice point, which is about traditional disease-modifying agents. We still use a lot of them. We don't use gold anymore. We don't use penicillamine. We still use a little bit of azathioprine in lupus, but mainly the four at the top of the four that you'll see used most commonly: hydroxychloroquine in lupus and rheumatoid, and these three across the board in rheumatic diseases. Let's look at each one of them just to remind you of how we manage these with you in general practice. Hydroxychloroquine, safe as houses, really is. It's safe in pregnancy and breastfeeding, which is why we like to use it in young women. The dose is usually about 5 milligrams per kilogram. We often underdose people. You can see if someone's 80 kilograms, they really should be on 400, but most people will get 1 tablet or 200. The caution for retinal toxicity, which is what everyone worries about, is really over 85 people and an eGFR less than 35. Young people, the risk is as rare as rocking horse poo. It really is. It is something that you need to check for. So they need an eye check every 12 months. And they can have that done at the optometrist because the optometrist can now do OCT and they can check that and let you know if there's any changes. So when you're managing someone we're on Plaquenil, the main thing is we want you to do is make sure they have that optometry check every 12 months. Other important points, if they've got an infection, you need antibiotics or they need surgery, don't stop it. And they can have any vaccine you like on Plaquenil. So Plaquenil is a pretty easy to use medication. Sulfasalazine, still used very, very commonly, the big yellow horse tablets, as we call them. The dose is usually up to about 4 to 6 tablets a day. It is safe in pregnancy and breastfeeding, even though you'll often read that it's not a category A, but it is safe. And we used to use it a lot in pregnancy and breastfeeding in people with rheumatic disease, but we don't so much anymore. Infection or surgery can generally continue unless someone's really unwell and needing a lot of IV antibiotics, then you can stop it for a week and they'll recover. No live vaccines, of course, but you can take any other vaccines on sulfasalazine and you don't have to stop. Live vaccines you have to stop. The main adverse we see, GI intolerance, very idiosyncratic liver abnormalities and neutropenia, and these are vanishingly rare, but when they're on the medication, what you'll see us doing is this sort of monitoring. Monitor liver function tests, full blood count, monthly for 6 months. Generally by then, nothing's going to happen. We drop to every 3 or 6 months after that, and they'll motor along quite well. Still see a number of patients on this medication. Methotrexate is the most feared medication by all patients who have Googled it and read about the chemo dose. We always make the point, this is not a chemotherapy dose. We are using a low dose oral weekly. In the US, it's called not Methoblast, it's called Rheumatrix, which is a much nicer name. These side effects here are really, if you manage the folic acid properly and make sure they take 2 tablets of folate on the day after the methotrexate, most people are not going to get these side effects. If they do, we stop and use something else. So they're the nuisance ones. The big ones that everyone worries about, liver. We never do liver biopsies these days. If it's causing persistent liver problems, AST, ALT, elevation, we stop the drug. Pulmonary fibrosis only ever happened in rheumatoid and was probably a rheumatoid phenomenon. It doesn't cause pulmonary fibrosis in psoriatic arthritis patients. So it's unlikely that this is actually a side effect of methotrexate, but we rarely see it these days. Bone marrow suppression, incredibly rare. And you do see a thing called pseudolymphoma in people on long-term methotrexate where they get quite marked lymphadenopathy and you stop the methotrexate and it goes away, incredibly rare. So what do you do with this one? Usually renal and hepatic function monthly because we want to know if the EGFR drops off because they can become toxic. Stop at least 3 months prior to pregnancy. Infection, stop it till they recover. We never mind. They won't flare. Stop the drug if they've got a bad infection. When they've recovered, put them back on it. Surgery, it is safe to continue, but our orthopedic surgery colleagues love us to stop it. So we always say, discuss when we talk about it. No live vaccines. You can give any vaccine you like with methotrexate, but always omit the dose of methotrexate post-vaccine. So 1 dose omitted post-vaccine improves efficacy. That goes for flu, for COVID, for most vaccines we give. So you just omit 1 dose post-vaccination. If you forget, don't worry, they'll still get a good response, but it's augmented if they stop it for 1 dose after. Our last synthetic is leflunomide or Arava, came along in about 1998. This is actually a rheumatic developed drug. It works on T cells and it works on an enzyme which I can never pronounce, which I always call DHODH. And that reduces activated T cells that are causing the rheumatic condition. So we use this one in rheumatoid and psoriatic arthritis. The dose is 10 to 20, but we can go as high as 40. All of these things are incredibly rare. And I always say to people when I tell them, if we stop the drug, they all go away. So none of them are terribly irreversible. The diarrhea is the one that's often dose limiting. This is always a good way to sell a drug. Most people get a little bit of weight loss. So you make sure you don't say that first or everyone puts their hand out and says, give it to me. So you do these other ones first and bring to the weight loss last. Never use in pregnancy. And if someone's been on this medication, they need a cholestyramine washout, which I'll come to in a moment. If it's a bad infection, stop it, restart when they're better, surgery, discuss. It has a long half-life and hangs around. Now, once you stop the drug, most of it's gone very quickly. But if we have someone who wants to fall pregnant, we do a cholestyramine washout, 8 grams, 3 times a day for 11 days. Your rheumatologist will organise that, and then we do the flutamide levels to make sure it's gone. If I have anyone with a severe side effect like severe diarrhea, I'll wash them out with this as well, and it works very well. So that's your basic synthetic DMARDs to remember. Remember, the monitoring is fairly easy, and they're quite robust in clinical practice with other medications, also robust with most vaccines. Remembering with methotrexate, the exception is stop it for 1 dose post-vaccine. So let's come back to her. So she's been on these, and what she's at now, she's at advanced therapy. So she's not responded. So I'm now in the position where I can move to advanced therapy as per the PBS guidelines. If I don't do that and give her a script, then these advanced therapies are going to cost her about $1,000 a month. But if I follow the guidelines, which we always do, and you can see for rheumatoid, it's very similar. It's 3 months of methotrexate and then 3 months of another drug. In psoriatic arthritis, it's 3 months of methotrexate, then 3 months of another drug. And in ankylosing spondylitis, if you've got X-ray evidence, you can jump straight to biologics. Let's move into the biologic landscape. There's always so many of them, so I've tried to group them together. Now, easy way to remember these: if it's a UMAB, then it's a humanized monoclonal antibody. If it's a MAB, then it's what's called a chimera. It's mixed with animal protein, like a mouse, like infliximab. All that means is sometimes you're more likely to get antibody reactions. So UMAB is humanized monoclonal antibody, and CEPT is just an antibody that's been put together with an active part at the top. Now, all of these are given by subcutaneous injection or by intravenous infusion, infliximab, and we'll come to how these behave and what you need to watch out for with them in a moment. But they're the commonest drugs we use in biologics. When we go down to this area down here, you see on rheumatoid arthritis, we have an interleukin-6, a T cell and B cell inhibitor. And we won't focus on those so much because we're going to focus on psoriatic arthritis, and we'll look at the 17 inhibitors here and the 23 inhibitors. And finally, we'll come down and look at the JAK inhibitors, which have jumped into center stage. So hopefully when you've finished and you can walk away from this, you'll have some sense of how these all work and how to monitor them. Remember that a monoclonal antibody, all it's doing is really binding to the activated molecule. So it's grabbing the TNF as it leaves the cell in the serum and before it hits the TNF receptor and activates all those things downstream. So let's go to practice points for these drugs now. Practice points for TNF inhibitors, they are incredibly safe. Yes, we all have problems with them, but overall we are using these in children with juvenile. They are safe in pregnancy. And if we do have someone who's pregnant, we give them the preferred one is sertolizumab because it does not cross the placenta. The rest of these cross the placenta after the 3rd trimester and we have to stop them, but they're safe in pregnancy, all of them. The major thing we see are injection site reactions. We screen for TB because it can reactivate TB. And if we see tuberculosis on the quantiferon test we do, we treat it and then we treat them anyway. SLE-like syndromes are very rare and they stop when you stop the drug. Central nervous system demyelination, we don't use them in people who've had MS, but this is vanishingly rare. I've had one case of optic neuritis in 25 years using these medications, so it's very, very rare. There's no increased solid organ malignancy, lymphoma, breast cancer, or anything else with these drugs. They're not demonstrated to increase risk. The only thing with any immunotherapy is the increased risk of SCC and BCC, particularly in Australia. So any immune therapy, everyone goes to regular skin check at the age of 45. So basics again, if someone gets an infection, stop. You don't give them the next one to recover. If they've had it, and often what happens is they give the injection and they're not due one for 2 weeks and they get sick, treat them as you normally would with antibiotics. The only trick is a lot of the time they'll present just feeling unwell And if you do the ESR and CRP, they'll be through the roof, but they won't have a lot of focal localizing signs. So sometimes you've got to have a lower threshold for antibiotics in these patients because they'll often become quite unwell quickly if they're not treated with antibiotics, simply because they don't present, as I said. The classic is a UTI that presents being unwell, and they won't have dysuria, but they'll have a rip-roaring urinary tract infection that requires treatment. No live vaccines, but all other vaccines can be given, and you do not need to stop the drugs to do it. And surgery, discuss. Probably safe, but best to discuss it with us before going ahead. Minor surgery, tooth, endoscopy, colonoscopy, skin lesion removal, keep going. Remember, I'll just take you back there. Interleukin-17s we're going to discuss now. These are another type of biologic that work on the interleukin-17 cascade. And the main thing I want to point out with these are, again, quite safe. The biggest thing to watch out for with these is people who get candidiasis. Now, these things have a very peculiar way of working on our defenses against candidiasis. And so often you'll see a person who'll present with vaginal or oral candidiasis on these medications. Our usual treatment, if topical is not working, is to give them fluconazole. That's actually on the PBS oral for this sort of immunosuppressed person, and usually give them 30 days. They have a repeat in case they need to use it, but most times you give them 30 days of fluconazole at about 100 milligrams daily. They'll settle very quickly and you can continue therapy. Same with these. Infection, just stop it until they recover. Vaccination, no live vaccines, but everything else is on the table. And surgery, discuss. That's all these down here. Cosentyx, Taltz, and a new one coming out called Bimilix. You can see that the theme is very similar for all of these drugs. Stop if they're sick. Vaccinations are okay. Discuss pregnancy. TNF inhibitors are fine. The rest we discuss, and surgery we discuss. This is a newer one. This is called Tremfya. This is very interesting. The dermatologists love this medication because it's extremely good for skin. Its name is guselkumab. It works on the IL-23 cascade. Now, this one is really interesting in that the safety profile is excellent. It's only once every 2 months. And again, the same principles. With infection, usually because it's every 2 months, you often catch them in between injections. So there's very little point in saying stop. So you just treat them as you normally would. Again, having that slightly lower threshold for antibiotics. No live vaccines, but every other vaccine can be given on this medication. And surgery, again, we discuss. Pregnancy for these two, 17s and 23s. Look, the dermatologist will tell us that they have good data, and many of their patients who've fallen pregnant on these medications have had normal pregnancy. So there doesn't appear to be an increased risk, but we don't have as much data for we do for TNF inhibitors. So at the moment, if I'm discussing that with the patient, I will say, look, we'll discuss. Usually we'll continue right up into the moment of pregnancy and then stop at that point, depending on how they're going. Let's just talk briefly about another class of biologics, and then we'll go back to our case. These are the Janus kinase inhibitors. Someone had a lot of fun with this in the lab because Janus is the Roman god of doors, looks forward and backwards. So you can see here's Janus kinase here looking forward and backwards into the cell. And that's, of course, where we get January from, looking forward and backwards into the year. They have a number of different ways that they work, and they always end in nib. If you see a nib, it's going to be one of these small molecules: upadacitinib, tofacitinib, baricitinib. The way that they work, interestingly, this is a cell. Imagine this is a cell in a joint. In the middle is the nucleus here. Now, a cytokine, it might be TNF, has got to come down and dock onto that receptor to get into the cell, to get the cell to make inflammatory things. Interestingly, so is IL-17, so is IL-23. So you can see what I'm getting at. If you block in the cell here, you're catching any cytokine or inflammatory chemical that the person is throwing at it. Now, the activated Janus kinase is activated by the receptor. It then phosphorylates and falls down into the nucleus. And these are called activated STATs. Down they go. And they then tell the nucleus to produce a whole load of inflammatory cytokines you can see at the bottom here. Now, this is Xeljanz, which is a nib, a tofacitinib. What you can see that it does, it actually blocks here. It blocks the JAK from binding and phosphorylating the STAT. Therefore, you get much less inflammatory chemicals coming out at the bottom. Obviously, it doesn't shut down the cell completely. Otherwise, it would be catastrophic, but these are very effective medications. But there's a couple of things about them that we're going to discuss a little bit more. Now, firstly, with these, there is an increased risk of hyperlipidemia. So we have to be aware of that. And there's an increased risk of myocardial infarction in people over the age of 65 and smokers. So we use caution there. The other thing is the risk of herpes zoster. We're going to talk about that. But with this one, again, vaccination, no live vaccines, but any other vaccines are on the table. You can give them. Surgery we discussed, it has a very short half-life. These are oral, they're given daily. You stop them within 48 hours, they're out of the system. So same thing. Importantly, if you have an infection, it's okay to stop them until the patient recovers. So this young lady, for example, she goes on to secukinumab, which is an interleukin-17 inhibitor. And very often we are, as rheumatologists, trying to get the best outcome we can. And it is, unfortunately, a bit of a lottery. We go on the phenotype we see in front of us. So lots of skin usually means an interleukin-17 rather than TNF. But we can see that although she gets better, she doesn't get full improvement in her psoriasis. She's still got a lot of fatigue and pain, and her ESR and CRP is still elevated. And so this is just to show you one of the side effects that can occur with adalimumab. She then went on to adalimumab with methotrexate, and she got a paradoxical reaction. So many people, when you put them on a TNF inhibitor with psoriasis, they get a thing called interleukin-23 escape, so which meaning the upstream chemicals upstream from the TNF ramp up. And so this is what happened to her and her nails on TNF inhibition. So clearly in her, TNF inhibition wasn't the way to go. And then she actually went on to upadacitinib, a JAK inhibitor, and she's done exceptionally well at this stage. So we moved her in that direction because she really was struggling and she needed rapid improvement. So her weight's still unchanged, and that's an issue we'll discuss. So 3 key issues I want to take you through in the last 15 minutes, just based on what we said there. Zoster, because it's really important in rheumatology patients, and particularly in our patients who are on immune therapy. The second thing is lipids, which you can treat better than I can, but I want to point out to you the increased risk of patients with rheumatic disease, and they should be treated as high-risk patients in terms of their LDL target. And finally, options for weight loss, because importantly, we have to help these people to lose weight if they're going to get better. So herpes zoster, you all know the basis of herpes zoster. Most people, even if they don't remember, in fact, if you look at the data, probably about 95% of people had chickenpox when they were younger. This is before the chickenpox vaccine, which is given out now, as you know, to young adults. And it is going to be interesting whether we see zoster. We probably will see zoster in those people who've had vaccination with the chickenpox vaccine. That's what our infectious disease colleagues are telling us. So we'll probably have to look out for them in the future as well. But let's deal with the people we know. So certain medical conditions are certainly associated with an increased risk of developing shingles. Rheumatoid is one of them. Lupus is another one. Lupus has a much higher risk. IBD, and chronic renal disease, of course, but also psoriatic arthritis as well. And this is before you give them drugs, they have an increased risk. So there's something happening with their immune system which makes them an increased risk of reactivating zoster. And it's a terrible illness, as you know. We want to avoid it if we can. Something else to point out, these are the gold are patients with rheumatoid, and the blue are healthy adults. Now you can see that at every age, rheumatoid patients have a higher risk of herpes zoster, and that risk increases rapidly after the age of 50, as you would expect. But importantly, even down here, they're at a higher risk. The same thing goes for patients with psoriatic arthritis. Gold is patients with PSA, blue healthy controls. Not so much of a risk when they're down here at 21 to 30, but as soon as you get up to 50, up it goes. But there's also an increased risk at these levels between 30 and 50. So just to remember, rheumatic patients are at increased risk. And particularly like our patient, if they're on a nib, upadacitinib, baricitinib, or tofacitinib, that's Rinvoq, Olumiant, or Xeljanz, the antiviral and inflammatory responses are dampened down by the JAK-STAT pathway inhibition. And so they're 3 times the risk of getting herpes zoster reactivation. Now, you're all very much aware of Shingrix, so I'm going to talk about it briefly, because you can give this vaccination with any of the medications that we give our patients. Remember, it has an antigen, glycoprotein E. The adjuvant system is a well-patented adjuvant system. The GSK has also used in their respiratory syncytial virus vaccine, and it gives you a much more sustained response. This is looking just at the data from people who are greater than 50 years of age. We did this trial in our clinical trials unit, and what's interesting is the level of protection that you're getting. This is the follow-up up to 3 years and 3.7 years. These were patients who are 50 and those who are 50 and those who are, this one's patients greater than 70. You can see the level of protection is well over 95%. And that protection, I've got to 10 years, actually goes to 15 years now. So that protection drops off very slowly. When you look right out at 10 years, we're still getting, if they get the 2 injections, remember, they've got to have 2 injections based on the second one 2 to 6 months after the initial. So it's very, very important. And again, the efficacy in people who have got who are severely immunocompromised, we also see reasonable effect as well. Now, the studies here were done in patients who'd had bone marrow transplant. They'd had chemotherapy. So these are severely immunocompromised patients, but they're still getting reasonable responses even when they've got quite significant immune suppression, and the efficacy of preventing post-herpetic neuralgia is in the same study was about 89%. Now, I put this here because up until recently, you could only get free Shingrix for over 65. In the last 2 weeks, the government has changed their mind on the PBS after lobbying, and now anyone over the age of 18 who's on an immune suppressant drug, not just people who are severely immunocompromised, will be eligible under the PBS to get this medication or this vaccine if they require it. So just to remember as that's coming through, because what you'll probably see our letters saying more and more, this person's eligible for the Shingrix, please proceed with the vaccination. So this is our young lady, and she did get a zoster vaccine, which protected her. Her weight remains unchanged. So even though she's gone onto this very effective medication as monotherapy, and after 4 months, remember this is a nib, so it's a JAK inhibitor, and this is Rinvoq. Pain's better, fatigue's better, very little morning stiffness. Can't lose weight still, even though she's moving more. Psoriasis and nails are 70 or 80% improved. So we're happy with that. But look what happens to her lipids. So what we often see on the nibs is we see elevation of the lipids. Her total cholesterol goes to 6.8, LDL's 4.2. Now, it's really important that we address this in these patients because they are at higher risk of cardiovascular events, patients with PSA and RA. Now, her baseline cholesterol was normal, and the question patients often ask me is, well, what if I just stop that? Will it go back to normal? Interesting, it does. It reverts, but they revert to a slightly higher level. And once we lose control, as you saw how bad she was, if we lose control and try to go back to another medication, then we're also in a very difficult situation for this patient. So we tend to press on and treat the lipids. And so we use the cardiovascular risk calculator in our rheumatology patients. And this one goes through, you've probably seen these in clinical practice running through. But importantly, rheumatic disease is an independent risk factor, so that it doesn't often come up in these cardiovascular risk calculators, but rheumatoid and psoriatic arthritis are independent risk factors, and it puts a patient into a high risk category. So that when we're talking about how we manage their lipids, of course, we stop smoking. It's the first thing we try to attempt with them. Ensure their blood pressure is well controlled. And as rheumatologists, we have to go back to being physicians and taking blood pressures, which we encourage our trainees to do. We use a cardiovascular risk calculator. We will often, if someone has, say if they're in their 50s, we've got a couple of options, as you know. We can do a CT coronary angiogram to look for a critical lesion. But importantly, I think we've got to say that if it's normal, we don't just wash our hands and say, okay, we're all good. Because some of the emerging literature in the aged care field shows that there may be an associated with cognitive loss and middle age, uncontrolled high LDL. Now, that data is not confirmed yet, but I think there's a number of reasons to look at using things like low-dose rosuvastatin to reduce LDL to reasonable level, particularly in rheumatic patients. So we generally have a low threshold for treatment. As you're aware, managing LDL, we usually use a high-potency statin like rosuvastatin or atorvastatin. And if the LDL target is not achieved, then we'll add in ezetimibe. And by that stage, we're usually working very closely with you or working with the cardiologist if we move on to a PCSK9 inhibitor. And remembering that most times if we use low-dose rosuvastatin, that we will be able to achieve with 5 to 10 milligram doses, decent control of the LDL, which is what we're after. Just to remind you of the guidelines, and I know this is sort of stepping out of the rheumatology space, but more and more we have to step into it as rheumatologists because we are treating patients with drugs that do increase cardiovascular risk, and our patients are at increased cardiovascular risk. So we're looking really at individuals at high risk. So we really want the LDL less than 2 in rheumatic patients. Not less than 2.5, less than 2. That's what we're really looking for. So we encourage you to get the statin to a level to get it down to that level, and that appears to reduce the risk in the long term in rheumatic patients. Okay, finally now just talk about some practice points in weight loss in rheumatic disease. With someone like with psoriatic arthritis and psoriasis, these patients are more prone to obesity and they're more prone to gout, they're more prone to a lot of metabolic factors. And there's a number of issues involved in that. But importantly, inflammation or the inflammatory response equals an increased risk of cardiovascular disease. It also has other knock-on effects, being overweight, of course, diabetes, hypertension, and so forth. So what we want to do is firstly work on diet to try and help these people to lose weight. But when that fails, and so often, as you know, better than I do, it does, even though your best efforts, people cannot lose weight, then we've got to look at alternate methods. So the approaches beyond a diet and a dietitian include using appetite suppressants like phentermine. Orlistat we don't use a lot of. It really just inhibits fat absorption and gives people diarrhea. Our endocrinologist uses a fair degree of phentermine as an initial agent, doses of 15 to 30 to 45. It does tend to cause a bit of hypervigilance in some people. Interestingly, I've had some people with ADHD who've got on this medication, felt a lot better, and then gone off to get that sorted out somewhere else. But that's an aside. Phentermine is a reasonable choice in some of these people, but it doesn't work for everyone. Of course, metformin is used. People probably lose about 5% of their body weight at most on metformin, but it does suppress hunger. And then, of course, the GLP-1 agonist, which right in the news at the moment. Bariatric surgery is still used, but more and more becoming a blip, which probably become a blip in history as less and less people requiring this option. So just to look at the GLP-1 agonists and look at the different comparisons here, you're all familiar with this medication, semaglutide or Ozempic, reserved for patients with diabetes, and it's a weekly dose. We start at 0.5, start at 0.25, I'm sorry, go to 0.5 and then to 1 if it can be tolerated. The other one that has entered the scene is Wegovy, which is semaglutide as well, but there's a cost difference between them. I think Ozempic is 180. I think Wegovy is about 280, 260 to 280, but this one has been TGA approved for weight loss. So this is the one you're supposed to use if you're using it for weight loss alone. Our endocrinologist still uses some liraglutide, Saxenda, although it's a daily dose, and for many people they struggle. It causes a lot of side effects. And Mounjaro is still also being used as well, off-label for weight loss because it's still not on label for weight loss from the TGA. Problem for these and the problem for my patient is cost. Long-term effects, probably the big things we're seeing, pancreatitis and GI upset are the big things. If they've got a family of thyroid cancer, you really do need to be careful. But interestingly, short-term bursts of these medications probably have less side effects than we thought. And they're entering the treatment paradigm in many patients as a way to help them get that initial boost in weight loss, that 10 to 15 kilograms, and during that time, try to teach them effective eating habits to try and keep the weight off. Unfortunately, non-sustained responses occur in many people, and they do end up going back onto therapy. But I put these here because I think the pipeline for these medications is enormous. In our clinical trials unit, we are doing 6 trials of agents like this in OA knee, in obstructive sleep apnea, in people who are overweight, who are pre-diabetic. So they are going to be something that we see more and more used as part of our treatment algorithm. Finally, before I finish, just a word on bariatric surgery, because a number of my patients still ask about it. The most common bariatric surgery done is an excision, and that bit goes into the bin, as Gary Yee puts it. So they don't get that bit back, it's gone. What seems to happen then is much of the gastric surgery is not only the reduction in the size of the stomach, but the fact that the food moves quickly to the ileum and you get GLP-1 release. And so you get a feeling of satiety very quickly. And so that works. You see that what happens when you look at follow-up over time out to a year, people lose weight very, very nicely after they've had gastric surgery. You would have seen this in clinical practice. A large proportion, unfortunately, then regain their weight through poor eating practices, high caloric foods, and so forth. So our gastric surgeons say that this will probably continue to be used over time, but it'll be used in very specific cases, and it will probably be supplanted by things like the GLP-1 agonists over time. So bring you back just to talk about, we have an enormous number of medications now available to us in rheumatology, but if I take you back to managing those synthetic DMARDs we talked about, methotrexate, leflunomide or Arava, sulfasalazine or Pyrrolin, and Plaquenil or hydroxychloroquine, the rules around managing them are fairly simple. And we are happy for you to stop them if people are unwell. Remembering particularly for all of these drugs, you should have a lower threshold usually for antibiotics when people are unwell. TNF inhibitors are the mainstay, and we spoke about those. They are safe in pregnancy, and you will see them used an awful lot in our patients. We talked about IL-17 and 23 inhibitors. We also talked about the JAK inhibitors and some of the particular challenges they present, including the risk of herpes zoster and also managing lipids in people with rheumatic disease. So thank you very much for your attention. I'll stop sharing now and really happy to take any questions at all.
Thanks, Paul. That was really good. I enjoyed learning about all these things. Maybe just before some questions come up, often these patients, you see them on one of these agents. I mean, you're working with them, so you remember all their names and what they are. Is there sort of some place you can head to quickly to sort of get a sense what the patient's on, to look it up yourself?
No, it is very difficult. The Australian Rheumatology Association website has some information where you could go, and it usually gives you just a short list, but it is really difficult. It's a bit like the oncology. When you look at all the oncology medication, it's hard to find a one-stop shop. Maybe that's something I should look at, Oliver, getting one out
I've
there.
seen JAMA did do a publication recently on this. I don't actually have the name, but I know I did see a review being done with the intention for the general physician and the general practitioner to access it. Yeah, but I think that would be a good paper. So we'll look forward to you doing it.
I've got there's a couple of questions there, Ivor. One says, are undifferentiated seronegative cases? Yeah. So the term seronegative arthropathy, we used to use all the time for anything that wasn't seropositive rheumatoid. So you'll still see it used very often. But when you hear seronegative arthropathy, what you're really hearing is undifferentiated case. Doesn't fit into psoriatic arthritis or rheumatoid, but it's really just at the moment a person with inflammatory arthritis And often you can start initial treatment and move them along while you're waiting for things to declare or for you to make up a decision on what you think it really is. Second question is fluconazole for 30 days with other comorbidities, say on statins, could affect their LFTs. Yeah, it can. In my experience, it doesn't really. I mean, it doesn't affect them to the point where they become unwell and it settles very quickly. If you're particularly concerned, I just do bloods every 2 weeks while they're on it and make sure their LFTs stay within good order. But it's not practically usually a problem to use fluconazole 50 to 100 milligrams for 30 days while on a statin. There's a potential interaction, but in real life, I think that it's very, very rare to see problems.
Well, I may just ask you another question, because the cardiovascular risk side was quite interesting, because it seems that the cardiovascular risk calculator seems to omit important organs of the body, including the kidney and the rheumatoid system. So I think that is something that is missing from that. I suppose it's an important take-home message.
Yeah, absolutely. Yeah, I think that the cardiovascular risk calculators are really applicable to the general population who don't have any of the chronic diseases. So they work very well for someone who's presenting to you with hyperlipidemia, might be an ex-smoker, they might have hypertension. So they're good at looking at the traditional risk factors and putting them together. But you see someone, in your case, as you say, chronic kidney disease, rheumatic disease, they haven't been able to, or I'm not aware of any that incorporate that. So we often have to do it manually as a rheumatologist to say, well, I'm going to add in, and the usual figure we give is we usually add in, 1.5. You sort of say to yourself, well, if I think they're a mild risk, they're a moderate risk. If I think they're a moderate risk, they're a high risk. And that LDL target I gave you is usually what we aim for in anyone with rheumatic disease, because the outcomes tend to be, when you look at the studies longitudinally in rheumatic patients, they tend to have better cardiovascular outcomes with that lower LDL. Sorry.
All right, a few more questions that have come up.
What proportion of RH patients need joint replacements? Lots more. And do you know why? Because they're exercising more and wearing out their joints. So we had this discussion recently. If you look at joint replacements in the hands, because we don't walk on our hands, they've disappeared. So basically, when you talk to the hand surgeons, occasionally now we are sending people to have first CMC reconstructions, that sort of thing. But in terms of the hand joint replacements we used to do, they're going to the history books. In terms of knee and hip, we're actually, as people get older and they're moving more, there's an increased frequency just with age, but not from the rheumatoid. The other thing about rheumatoid, as you know, is that the people used to die in their 50s and 60s from cardiovascular disease, and that's now been abolished. So, in terms of your question, yes, there's more of them, but they're mainly because people are getting older. Asher says the calculators don't calculate well for over 70. Yeah, except that one. That's great. And Melissa Riddle, thank you. Yes, the new CVS calculator does include rheumatoid. Wonderful. That's great. Thank you, Melissa. I'll make sure I get that on my desktop. That's good. Thank you.
So thanks again for your time.
Pleasure.
Appreciate it very much. Thanks everybody for participating this evening. And of course, we look forward to your feedback and any suggestions for the future, and look for people joining us to be involved with the integrated care group. Thank you. Thanks very much. This was very enlightening.
Thanks, Ivor, and thank you, Associate Professor Bird, for your presentation tonight. Please join us next month for the lung function tests update, which is, I believe, Tuesday, 15th of October. And the evaluation survey will pop up on your screen, so don't forget to complete that. And we will start planning our topics for the 2025 calendar, so please put any suggestions you have for any speakers that you want to hear from St George Hospital. So thanks again, everybody, for attending and for your time tonight. Thank you.
Thank you. Bye-bye.